All right. I'm going to give us another minute or so, just so we let everyone trickle in from the virtual waiting room. And we wanted to thank everybody for joining us this evening. We're very excited about this webinar. This webinar is going to be reviewing clinical controversies in GLP-1 receptor agonist management, in particular, tips and tricks for the foregut and bariatric specialist. The format of this webinar this evening is going to be 3 case discussions. So we're going to present the case, then we're going to open it up to our panelists here on the call, discuss some of the clinical nuances of each case, and then we're going to allow about 5 minutes for questions after each case. So please engage with us because we're excited about this topic and speaking about it with you. And I'm going to hand this over now to Dr. Hudson, who's going to take us into the webinar.
Thank you so much, Carolyn. My name is Catherine Hudson. I'm an assistant professor of medicine at University Medical Center in the weight loss and bariatrics surgery clinic, and I'm from LSU in New Orleans. I'm going to tell you first just a little bit about our objectives. Tonight, we are planning to discuss the current strategies to optimize GLP-1 receptor agonist tolerance and efficacy in the context of a comprehensive obesity treatment plan. Our second objective is to understand how multidisciplinary specialists manage patients on GLP-1 receptor agonists when they are preparing for foregut and bariatric surgeries and after these surgeries have taken place. I'm going to go ahead and introduce the rest of our panel tonight. We have Dr. Guilherme Campos. He is the Paul J. Nutter Professor of Surgery and Chair of the Division of Bariatric and GI Surgery at the Virginia Commonwealth University School of Medicine. Next, we have Carolyn Newberry, our Assistant Professor of Medicine and Director of GI Nutrition in the Division of Gastroenterology at Weill Cornell Medical Center. And lastly, we have Dr. Manuel Galvo Neto. He is the Director of Bariatric Research and an Affiliate Professor of Surgery at Orlando Health. So welcome to all of our panelists. Let's go ahead and get started. So our first case is a 42-year-old female with a past medical history of class 2 obesity with a BMI of 37. She also has hypertension and hyperlipidemia, and she undergoes a successful sleeve gastrectomy with a 40-pound weight loss, which is 18% total body weight loss, over the next 12 months. With weight loss and dietary changes, her hypertension and hyperlipidemia improve and she's feeling well. But at her 2-year post-op, she's injured at work and she requires an ankle surgery. So this leads to a drop in her physical activity and an increase in caloric intake, and therefore she regains 20 pounds. She wants to discuss options for weight regain, including consideration of a GLP-1 receptor agonist. So here are some discussion points for this case. We don't have to discuss them all, but I'm going to let the panel go ahead and start with our first discussion point and see how many we can get through. So are GLP-1 receptor agonists safe in post-bariatric surgery patients? Dr. Newberry, do you want to start us off?
Sure. Yeah, I was going to see if the surgeons wanted to jump on that initially, but I think there is mounting evidence that there is both safety and efficacy of these medications in post-bariatric patients, and these medications can be options for weight regain or also weight loss maintenance post-operatively. I think there's a lot of nuances to what patients do best with these medications, what patients are appropriate, what patients tolerate them. And yes, I would actually like to hear the perspectives of our surgical colleagues here on the call to understand how they're really having these discussions with patients after surgery.
Hi, Jeremy here, jumping ahead of Galvão. So very common scenario, weight regain after sleeve gastrectomy. I would say we see in about 15 to 20% of the patients, sometimes more, or desire to lose more weight as well is part of postoperative care in sleeves. Before talking about the GLP-1, I think every bariatric program revisits the patient's behavior, in terms of how they're related to food, how are they related to exercise, are there opportunities there, and is there any other stressors in their life? Do they need to see a psychologist again to be able to readjust? The behavioral component is essential. We will revisit that. I agree 100% with Carolyn that GLP-1 receptor agonists are safe in the majority of the patients that have bariatric surgery. There are the standard contraindications for GLP-1 that also are valid for this patient population. And then the discussion is which one of them should we choose, right? I mean, then step back a little. I think most of us sort of deal with this on a daily basis. There are basically three of them that you can use, right? There's the daily injection, there is the liraglutide, there are the weekly injections, the semaglutide, and the more recent one, there is tirzepatide. There is also weekly injection. Our preference, if the patient can have, is to actually go directly to tirzepatide because it is the most efficacious one, with a little bit less side effect reflux-wise, and then titrate that. But a lot of the times, insurance mandates what these patients can have because they don't approve these medications. I'd like to hear what Galvan thinks about it.
Yeah, that's a very day by day what we see on a daily basis, what you described, Guilherme. Just to spice it up, what we have done in the past that called those patients back to get to the embrace it by the multidisciplinary team. Now in the era of GLP-1 analogs, they are much more efficacious of what we have done in the past. And interestingly, that you say that you go directly to tirzepatide. In our case, we go on the beginning. We go to liraglutide directly on that because it's cheap. You have found compound. If you have a denial of the insurance, it's easier the patient to get on that. And it's a very, very interesting difference of vision on that direction. Almost is the same, but and we fight a lot with the insurance, and we are getting some insurance to pay for the GLP-1 analogs on some of those patients on that. So I like it. I personally like it because I do bariatric endoscopy, and GLP-1 analog is our ally in a lot of those procedures.
Our main reason to choose tirzepatide post-sleep specifically is because of the more recent data. There's a publication in Gut last year, TriNext data set evaluation, in which they see that patients that have reflux on the liraglutide, on the daily ones, are at high risk for erosive esophagitis, strictures, and Barrett's. And I look into every sleep patient, and I'm always concerned that they may either have a silent reflux or have some component of reflux. So for sleep specifically, we prefer tirzepatide, but it's not like a yay or nay, right? And it's a judgment call.
Yeah,
I can be challenged.
Because GERD was not described.
Yeah. Agreed. And I think it's actually a good point to go into even the second discussion point, considerations before starting a patient on these medications to modulate post-sleep waking, because we're talking now about a patient with sleep, and we know that, yes, these patients are at higher risk of developing reflux and its complications. Catherine, how are you approaching these patients in your clinic, and which medications are you actually counting on for them to start with, if you had every option available to you?
Well, my practice usually is to start with, I like the weekly dosed medications. If I'm worried that the patient is going to have a lot of side effects, if maybe reflux is already an issue, then I might start with the daily dose because then we can kind of come off quickly. But I like to go with semaglutide because I think it's just a little bit more effective and gives a little bit more control. And we don't always have to go to the highest dose right away. I'm a big proponent of staying at lower doses early and seeing what kind of weight loss we can get at lower doses, because I feel like no matter how great the surgeries are, the medicines are, life tends to get in the way, and people tend to regain when things happen. Like with this patient, you know, she's now off her feet and she's eating a little bit more. But if this can just get her through that short period of time to get the ankle surgery, get back to where she was before, then maybe she doesn't need to go to the biggest gun right away. And then in the future, if this happens again or something different happens, now we still have more drugs available to us. We haven't used our biggest gun yet. So that's sort of my mentality. If I could have any drug I wanted with insurance coverage. So, yeah.
Right. And I think that mirrors, there is some data on, the physiological changes of GLP-1 levels post-bariatric surgery and how these are potentiated in a different way than patients that are preoperatively. So I agree that potentially we don't need to be using the higher potency drugs in patients. I anecdotally just had a patient this week who was post-sleeve, who was on 0.25 of semaglutide. So the starting dose never actually up titrated because some things happened in her life and she missed some follow-up appointments and lost like 15% of her body weight in a 6-month period. So I had really, really wonderful effect from drug.
Yeah.
Yeah, I do think that we need better data to guide these decisions, and that's an opportunity for clinical research. It's all opinions, and and again, we do this on a patient by patient basis. But even talking about reflux, I had patients who were on semaglutide and developed rip-roaring reflux, even though it's the long-acting, and actually tolerated liraglutide. So yes, majority of the short-acting have more reflux based on best available data, but individual decisions are made in the office. So
Yeah. And before we open it up for questions on this case, I just want to ask this question. You know, we have on here, what are the other options for weight regain in this patient? I think the obvious thing here is a conversion to a bypass. When would be the time when you would switch to a revision for this patient or a conversion to bypass instead of using a GLP-1 receptor agonist?
you wanna tackle that, Galvão? I'm happy to do
If
it.
you tackle surgery, I tackle endoscopy.
Okay, so look, just to before answering directly the question, the physiologic changes, metabolic changes in sleeves are a little bit more short-lived than in bypass. There is good publication showing that a year or two after a sleeve, maybe the hormonal changes will decrease. And the bypass, usually we have papers showing that 5 years the metabolic changes are still there, the GLP-1 changes. So that's one point. Second is if they regain weight above what is indicated regularly for bariatric surgery, they are above 35, or they have above 30 with comorbidities, and they can have a conversion. Our preferred conversion is still a conversion to a gastric bypass. However, there are other options. There you can do a SADI, and now there's the new kidney block. There is the lateral duodenal jejunostomy. That can be even done with a magnet. My preferred approach at this point still is a conversion to a gastric bypass, and these procedures can be done laparoscopically, but the patients go through the program again because insurance will not approve without them going through the program again.
Yeah, I like the options endoscopically. What we can offer to these patients our groups published two different approaches to that. One is to revise the sleeve gastrectomy with an endoscopic sleeve gastroplasty, meaning we're gonna resuture, retight, recalibrate these sleeve by endoscopy, and the results are very, very promising. 2 years getting in between 15 to 20%, much better than when we do the endoscopic approach to failed bypasses. And also, as Guilherme described it very well, and they are now FDA approved. So the duodenal-ileal anastomosis with magnets by the two companies that are now approved by the FDA, and our paper, seminal paper on that, get on the sleeve with weight recurrence, we got 17% a total body weight loss with very good results on the metabolic part by doing that. Is a hybrid approach, laparal endoscopic. So we can have the two options, and this the we offer, but surgically, our group offer not gastric bypass. We offer conversion to SADIs, because we are big proponents of doing SADIs and duodenal switches on these patients, because there is data, limited data for sure, that the conversion from a sleeve to gastric bypass, they don't add that much as weight loss as we can do that with those malabsorptive, call it malabsorptive procedure in that direction.
Yeah, I agree with you that there's greater weight loss with a SADI or the duodenal switch. However, there's an Achilles heel to that, right? The greater weight loss comes with a greater rate of macro and micronutrient malnutrition. It depends a lot on the patient population that you treat. If you have someone who you know is not going to lose the insurance, who you know has access to high protein foods the entire life, who has health literacy that is appropriate to receive a DS or a SADI, I think, are okay with doing that. I see a lot of complications referred from SADI and from DS in my practice in patients that do not fit that criteria that I mentioned above. So I think it is a good procedure in the appropriate setting. In my setting, I work at the Virginia Commonwealth University. We are the safety net of the Commonwealth. We do have private payers, we have cash pay patients, but I still prefer an inferior weight loss with a little bit more safety. But it's a balance there, and that's another discussion.
Indeed.
And I think it's a good point to talk about the nutritional complications with these patients. And also, I think some of these post-operative patients that end up on GLP-1s, they do have enhanced GI side effects and are more restrictive in their diet. I mean, these patients, the sleeves, obviously, we don't worry quite as much about with that as the bypasses in terms of micronutrient deficiencies and things, but it's just something to consider that these patients need to be followed longitudinally with a dietitian. You know, they need to be looking at their macro and micro intake. They're on the proper supplements, et cetera. So they need close follow-up.
No doubt about it. And we just submitted an abstract to ASMBS. I'm not sure if I even can be saying publicly, but the abstract does show that if you compare sleeve and bypasses, the rate of micro and macronutrient malnutrition is similar. Sleeve and bypasses, there's this myth that sleeve gives you less micronutrient malnutrition. No, it's exactly the same. But then if you talk about DS or SADI, it's more. So they need to have follow-up. Yes. And even the medication itself, right? The medications are associated with excess lean body mass loss. And taking these medications without follow-up, I think it's happening in the United States, but I think it is a problem.
Yeah. And I think, you know, one of the worst cases of subacute combined degeneration from severe copper deficiency I've ever seen was in a sleeve patient. And I think really the moral of the story is whether it's a bypass, a sleeve, or something else, or it's a GLP-1 inducing extreme weight loss, that's when you really need to worry about those micronutrient deficiencies that can cause some serious problems. So that's a good point. Good. As of right now, I don't see any questions in the Q&A section. You can put in a question anytime, and we can always come back to this case if there's a question in the future. Otherwise, I'm going to go ahead and move on to the next case. Our next case is a 24-year-old male who has a class 2 obesity with a BMI of 35 and obstructive sleep apnea, who presents for consultation to discuss his GERD symptoms. The patient notes that he's been on CPAP for 3 years, and that's managing his obstructive sleep apnea, and he's sleeping well. There are not any medications other than omeprazole 40 milligrams daily, which was recently started for heartburn by his PCP. They've been trying targeted lifestyle changes for the last 3 months after seeing the PCP, but has had minimal weight loss or change in reflux symptoms. So for our discussion points, we can just start off with the first one. What options does this patient have for weight loss. Who wants to start us off with this first discussion point about weight loss? I know the question is really about his GERD, but he is, in that range. So we can kind of talk about either of those things.
I'm happy to
Doctor?
start. Yeah,
Sure.
because I get this consult a lot as somebody who's seeing patients who are trying to figure out what modalities are best for them for weight loss purposes. And I think back in the question stem, we said this is a young patient who has a BMI of 35, so class 2 obesity. He has a couple of comorbidities already related to excess weight. And so he really has all the tools in the toolbox at his disposal. And I think it's going to be shared decision making with the patient what he actually ends up using. Obviously, diet and exercise and lifestyle modifications being foundational, but he hasn't had success with that thus far. And so I think both medications and procedural interventions, endoscopic and surgical, would all potentially be appropriate for this patient, depending on what he wants to pursue, what in real life, there's insurance coverage for, what his out-of-pocket expense would be, what his follow-up would look like, et cetera. And I think that, the reflux, this is hopefully a jumping off point that we can start to discuss sort of reflux as a complication of bariatric procedures and how we're really risk stratifying these patients and how we're managing weight loss in patients that have reflux symptoms.
Yeah. And I think as gastroenterologists, we sometimes need to cross over and have a discussion with patients about what their options are as far as bariatric or anti-reflux surgeries. And sometimes that can be, a difficult discussion if a patient thinks they're coming to a clinic visit with a gastroenterologist and suddenly we're talking about a bariatric surgery as a potential option even for the reflux symptoms. So I would like to know also what our two surgeons think. What is your BMI cutoffs or your range for saying I'll do an anti-reflux surgery versus a bariatric surgery? Do you have a cutoff? What do you use?
So the answer is likely yes, but in reality hits the road. Patient may not consider a weight loss procedure, right?
Right.
The one important aspect is I think that surgeons in general should be able to do anti-reflux procedures, should be able to offer bariatric procedures. Ideally, surgeons offer both. And the gastroenterologist should, if they only know a surgeon who does only anti-reflux, they need to become friends with a bariatric surgeon as well. But in my practice, we do both anti-reflux procedures, we do benign esophageal and bariatric surgery. So we have the privilege to be able to counsel these patients about it. But I have patients that come to my clinic exactly like that. He would never consider a gastric bypass, no matter what I tell him about it. It's his values, his perceptions. So we even published a paper, I think, in Foregut, showing it's a systematic review on outcomes of anti-reflux procedures in patients with a BMI above 30 and above 35. And it is acceptable to offer an anti-reflux procedure. There's likely a greater recurrence rate. And then when it goes above 40, it becomes problematic, right? That to try to offer an anti-reflux procedure. But sometimes I get patients who have parasophageal hernia with a BMI of 45, and they can't have anything else other than repairing their parasophageal hernias. And then it comes the multidisciplinary team to be able to have these patients lose weight before surgery. And even medications we use carefully on these patients. And something that I use very often for patients to lose weight is my team is very low calorie diet. Very effective, 500 to 800 kcal per day in a liquid form with 60 to 80 grams of protein. They're commercial formulations. Patients adapt to that. In a month, usually can shave off 25 to 30 pounds using VLCD. Very artificial, but at least to prepare the patient better for surgery.
Mm-hmm.
Yeah, to me, it's a moral internal dilemma.
Yeah.
And then you're gonna see this dilemma on the next patient. So yes, you can control this patient if the GERD is the driven symptom of this patient. You can control that with an anti-reflux operation like a Nissen, but that patient is gonna feel so well that he BMI gonna jump to like 8 to 10 points
Yeah.
in
I
3
see that
years.
over and over and over.
And then you have to convert this patient. Now we see now he's have severe obesity or clinically obesity, and now they will consider for a bariatric surgery. So that's believe me, this is a dilemma that we face. We know that those patients will end up on that, and then it's a conversion that is more risk for the patient. So it's a very debatable and very nice issue to debate.
Yeah, the informed consent part of it that is essential, and you need to be able to try to spend time. And in this patient, I do not make the decision on the first appointment. I ask them to go home, think this through, and let's talk on another day because this is a very important decision. Some patients just are referred to me, oh, go there and have an anti-reflux procedure. And my preference for an anti-reflux valve is a two-piffle application, just put out there. But that's not the conversation today. But informed consent, prolonged conversation, provide information, let you think, even if the patient said that he was not, they simmer at least with the information, so they understand how important that is.
And if we think about endoscopic treatment, we have a culprit of BMI. More than 35 is not the ideal patient. So just to be fair and talk about everything.
Right. I think it's a good opportunity too for actually doing some objective testing as well. I mean, this question stem, and it's a little unclear what degree of reflux this patient has. They have they note that they have heartburn symptoms. They were just started on a PPI. This may be mild disease. You may do objective pH testing on this patient, and it isn't. Maybe they don't even have pathological reflux to begin with. And so I think that can really help guide conversations. And I know AFS as a community is trying to understand more about developing guidelines of what type of objective testing prior to discussing weight loss and surgical planning should we be doing on patients, and what are predictors of poor outcomes. And if we can actually work together to figure those things out, I think patients will have better outcomes overall.
Yeah, this is an extremely important point that Carolyn makes. We jumped into offering surgical treatment. Obviously, before offering surgical treatment, you got to have objective diagnosis of GERD, right? Either you have Los Angeles grade C or D or a positive pH monitoring, right? In corroboration with evaluation of symptoms. Although Los Angeles grade B has been suggested as objective evidence, I don't believe in that. It's a paper from Italy. So anyway, you got to have objective evidence and evaluate severity of the disease as well, that put into context on what you do, and presenting that to the patient when he comes back. And I agree, sometimes symptoms are not a good guide. Maybe they have a normal pH monitoring. Maybe his heartburn is something else. Most patients don't go to medical school, and even some medical students don't know what heartburn means.
So I get myself catch again by what was described. If you describe GERD, I have to assume that this patient was tested. GERD printed means that you have tested the patient, because GERD symptoms is not GERD.
Yeah.
Correct. Yeah.
Great. Yeah. And what do you think, Catherine, about using a GLP-1 in these patients?
I mean, I think that's a great place to start in this patient. If you can induce even a small amount of weight loss, and the patient says, my symptoms haven't changed at all, or my symptoms are way worse, or, my symptoms are better, that helps you guide what's your next step. So I think you sort of, in a patient where they're sort of on the cusp, and maybe the patient hasn't decided that they want to do surgery, they say, I'd be willing to do a bariatric surgery, but I'd like to try this first. I think there's a great option to just try it and see what the patient's response is to medication. But I also wanted to ask, and I want to hear more about what everybody else thinks about GLP-1s, but I also wanted to ask about how often are the rest of you using Bravos to or pH testing on PPIs to help make a decision? If you're kind of on the fence about what you want to do, are you doing pH testing? Are you doing it on PPI? Does that play a role at all?
We
Go ahead, go ahead.
no. Well,
Correct.
I have been speaking way too much. Go ahead, Gavin.
So on PPI esophageal testing, if you go to the algorithms, it should be done if you don't clear that this patient have reflux with the standard measures. So
Right.
if you have any doubt, then you do that. But as a routine, I don't see it be used very often to clear, because first you're going to clear if the patient has or not reflux by objective measures of Bravo. And then still your patient don't qualify, but the symptoms are there, and then you go for, or even more, go even more, not a Bravo. So you have to escalate that to pH impedance. So then you can really classify this reflux, and for sure on PPIs that you're going to be a much better objective measurement of that, but it's not our routine.
Yeah, our routine is to do all Bravos off PPI, and we also are proponents of doing all the endoscopies 2 weeks off PPI. There's good data showing there is better diagnostic yield if you're going to do an endoscopy alone. You take them off PPI as well. I'm not sure what's your practice, Caroline, but we're trying to implement here to do all endoscopies off PPI.
Yeah, I mean, we definitely do our Bravos. I mean, very rarely are they done on acid suppression therapy. I think there are some select clinical scenarios where pH impedance on acid suppression therapy is helpful if you are having incomplete acid control, and a patient for some reason isn't a surgical candidate, or you're trying to sort of understand their next treatment options. But yeah, the Bravos are generally done off just because I think they're not as accurate. I mean, on therapy, it's just they're hard to interpret. In terms of whether the patients hold the PPIs prior to their endoscopies, it's an interesting thought that you would hold them to see if you actually develop some degree of erosive esophagitis or complications. And that would be very telling, I think, of how the patient would do. That's not currently in our practice right now, but it's maybe something, these are why these webinars are so great, because maybe it's something we should think about.
Yeah, there is a paper, I think it is in the American Journal of Gastroenterology, and during the Hawaii Foregut course, there was a lecture just on suggesting that is likely cost-effective and higher diagnostic yield, because what can happen is if you get there, someone has grade C or D esophagitis, you don't need to do the Bravo. Their diagnosis is there in their face. So that is the rationale behind it. But it's difficult to take all the patients of PPI. We actually had to modify the entire intake in our endoscopy suite to be able to do that, but we're trying.
Yeah, I think I agree. Sometimes the surgeons will say this patient needs a Bravo, and then I do the procedure and I see terrible esophagitis and I say Bravo over. And I agree, just like in this case, this patient is coming to you already having been on PPI for a month, started by their primary care doctor. So if the patient comes to see me and they're not on PPI, then I'm going to set them up for an EGD, and I'm not going to start the PPI until the EGD for that same thought process that I'd like to see the esophagitis and then we're done, and we know. I've never really stopped a PPI, but we do use response to therapy as a way to help us diagnose GERD. And so you could make the argument, okay, you've done a trial of PPI. If you're a little bit improved, let's see if we take you off if it gets worse, sort of trying to tease out that hypersensitivity, or is this truly GERD? But it's an interesting thought, and I hadn't thought about maybe stopping a PPI a couple weeks before the EGD just to get a good endoscopic exam. That's
I'll share
not
with
a
you
bad
guys
idea.
the papers, very interesting papers, really well done.
Yeah. Okay, great. Let's see. Any other thought processes about GLP-1s and how this patient could respond to GLP-1s and how that would change your management or your decision making?
I think it's variable how patients respond to GLP-1s in terms of their reflux burden. And I've had patients both have reflux improvement because they have significant weight loss, and particularly if there is any degree of gastroesophageal junction disruption, if they have a small hernia or something, I think they're so responsive to some particularly central adiposity, so weight loss, that they feel better. And, the degree of motility effects on patients also seems to be highly variable. And even when you look at some of the literature out there that looks at what degree of delay in gastric emptying looks like in patients, there's a wide range of degree, and many patients, the gastric emptying will actually go close to baseline within, a 2 to 6 month period, depending on the drug. And so I think this is certainly an option. I think a lot of our colleagues, particularly our endocrinology colleagues and our primary care colleagues, get nervous about using these medications in patients with reflux because of the known side effects. But actually, many patients can tolerate with proper management, lifestyle modifications, and acid suppression therapy that's appropriately used in conjunction with the medication.
Yeah,
Yeah.
I do agree what you say, and it's all over the place, the symptoms on that. And denying PPI because the patient have GERD and the mechanisms of action of the PPI and adverse events, this is not scientific. There's no data so far to do that. So still a trial and error. I think it's still very valid, the PPI on this page, especially because of BMI range. And then if it's that on the table, why not try?
Okay. Okay, good. We don't have any questions as of yet. Go ahead and enter your questions into the Q&A section of the Zoom if anything comes up. And I'm going to go ahead and move on to the third case.
Yeah, I would just say that's okay. I would just say on that case, if you're going to choose a bariatric procedure, the preferred is still a gastric bypass in patients with GERD. There is some nascent data that you may be able to do a sleeve in very selected patients who have early reflux disease, and the reflux disease is obesity related only, but we're not there yet. So a preferred bariatric procedure in anyone with GERD is still a bypass. And patients who cannot have a bypass, maybe you can do a modification of this sleeve to incorporate a partial fundoplication that is not still standard of care in the United States. And we don't have great long-term data as well.
And Manuel, would you say that if this patient's in the right BMI range and the GERD is there, would you consider an ESG in this patient?
That's a good question.
Good catch. Look, patients definitely they get better of reflux when you do ESG. The data we have is the ESG is non-refluxogenic. We don't have data that it can treat or ameliorate reflux. So if we think that when we do an ESG, by keeping the attachments of the greater curvature there, you're gonna put quite some part of the esophagus inside the abdomen, so it should benefit anti-reflux measurement or barrier, but we have no data, zero that will do an ESG and you're gonna get the reflux better. On a daily basis, we see that we should be studying that more properly.
Maybe you need to do an ESG and a TIF.
Oh, that's have been done. So there is on the literature around 10 cases published. More people are doing that, and some people even getting reimbursed to that. But again, what I see, those patients gonna get better. They're gonna regain weight. They're gonna have a severe obesity down the road. So you're gonna have a convert the TIF and the ESG to another thing. So I have mixed feelings.
Just do the king of operations.
You see?
Just do the king of all operations. Do the gastric bypass.
Very good. Okay, let's move on
to the king.
All right, case number 3. This is a 55-year-old woman with a past medical history of asthma, GERD, which we can assume was diagnosed by endoscopic or pH testing, and hypertension, who underwent a toupee fundoplication for hiatal hernia repair 6 years ago. She did well post-operatively, weaned off all acid-suppressing medication. Her BMI at the time of the procedure was 31. However, she comes to you now weighing 230 pounds, which puts her at a BMI of 36. And she's begun to complain of new dysphagia with regurgitation. So our discussion points, and I think this is a really interesting case because it really makes you want to know kind of more what was the workup on the front end before the patient had surgery. But let's first talk about what are the next steps to evaluate this patient from this point. So what's the first thing you're going to do?
So as I anticipated that this is going to happen, I rest my case because
Yep.
the patient feels well. So it means that this patient was never 30s. He was an obese, severe obese patient. And the thing was preventing him BMI-wise to be in the level of severe obesity was quality of life. He was not able to eat. And then you fix that. And then this patient is able to eat and have a good quality of life. Then in like 2 or 3 years, you see that. And this is what our moral dilemma when doing anti-reflux procedure instead of doing a bariatric procedure for this patient initially. So because Guilherme I know that a lot of those patients in very fast, like 2 or 3 years, they're gonna come back to a revision as severe obesity patients on that.
Yeah,
So
I counsel all my patients about weight gain after, they lose a little bit after, immediately thereafter, but I counsel them. It's part of my counseling because it's a common scenario. So what with the next steps of evaluation, I would say revision surgery, you got to get the whole package, right? You need to get a barium swallow, you need to get an endoscopy with pH monitoring, you need to get an esophageal manometry, and I always get a gastric emptying scan. That's the minimum that for you to have a comprehensive evaluation to try to make a decision.
Okay.
Yeah, I agree that you definitely need a lot of evaluation in this patient to sort of understand next steps, but it is really tricky. I often struggle with these patients in the BMI, the class 1 obesity category, and sort of how we're counseling them. Actually, there's an interesting question that Catherine, I think we can potentially tie into some of these conversations that, we don't have strict BMI cutoffs, and, I think using the data that we have and sort of having these frank discussions with patients about the different complications that can occur are so important because of that. And maybe there is a role when these patients are coming in these low 30 BMI ranges to discuss using anti-obesity medications or targeted diet and lifestyle changes to address optimizing their reflux and seeing if we can get them at a lower BMI class going into surgery. I mean, I think that this really could improve outcomes, but it's a challenging patient population.
Right. Yeah, and I think that's a great point, Carolyn. We've talked about this before, but we really need to see the adoption of anti-obesity medications into practices other than obesity medicine specialty clinics, right? Because there's a role for these medications in cardiology, in hepatology, and certainly in general gastroenterology. So, hitting this patient early with anti-obesity medications and trying to treat the GERD that way, I think is a great point. We already kind of talked about, is this a common complication of fundoplication? Yes, this is something that we see. Would this conversion be different if the patient's BMI had remained at 31? So if the weight hadn't gone up?
So the options of any conversion after a failed anti-reflux procedure is an anatomic repair. That is, if you have done something and failed, you can go back there and try to repair that anatomy again. And success rate is in the 80% range in the appropriate patient and if the first surgery was also done by someone who knows how to do surgery. You know, sometimes you get there, it's like a bomb went on the patients because someone that may not be too facile with this did something incorrect. But we also have recurrences, and it's easier to operate when someone that did in the initial operation is careful and a good surgeon. So anatomical repair is an option. But then a conversion from an anti-reflux procedure to a gastric bypass is one of the most difficult revision procedures that we do.
Yeah. And
But
I
it's an
think
option. It's a good option.
an option, yeah. And I think the other part of this case that we haven't talked about yet is that the patient is now complaining of new dysphagia. So does
Dysphagia,
that,
yeah.
yeah, so what does that make you think about? I mean, for me, if I know the surgeon who did the surgery, if I know where this patient got their workup, I'm assuming the patients had motility studies before they had this surgery, hopefully. But, you know, I work in a tertiary care hospital, and that's not always the case. So, you know, that's immediately where my mind goes to. Is there something wrong with the wrap? Did the patient have a weak esophagus to start with? Or they're having recurrence of their reflux that's interfering with their motility. So what are some things that you think about when you hear this patient is having more symptoms of dysphagia now?
So ordering the comprehensive evaluation is precisely because of that, right? The dysphagia after fundal application may be related to there is a reherniation of the wrap above the diaphragm that is causing the dysphagia. Or the wrap may be intact and the patient has developed pseudoachalasia or de novo achalasia years after a wrap that I've seen that. Or the patient developed or the surgeon maybe intravagus nerve, and the patient has post-surgical gastroparesis. So that's why a comprehensive evaluation is important for you to try to understand what are you dealing with.
Right. What about the phenomenon that we've discussed in preparation for this, where we sometimes see patients who are having difficulty swallowing, who sort of convert most of their calories to liquid calories because now they can't get solid food down. So now they're drinking lots of smoothies and shakes and maybe doing this without the help of a dietitian, right? Because these aren't bariatric surgery patients yet. How much does that play a role in weight regain in patients who have dysphagia or complications of foregut surgery?
We see that we see a lot that in patients with achalasia, so I think it's the same.
Mm-hmm.
Yeah, I think the dietary modifications that patients make are really fascinating. And when you really dive deep, I think a lot of times in these very quick appointments, we as physicians aren't very good about asking about the diet and what the patients are eating. And you can really uncover a lot because, yes, there is, when they make these modifications, they may be changing to, high caloric density liquids or shakes or exactly as you discussed to try to maintain calorie intake because they have so many limitations to eating specific solid foods and it really can actually lead to consequential, weight gain. And similarly, some of these patients also might develop some degree of malnutrition. I mean, you have, we talked about the lean body mass loss that we worry about in these patients when they're on restrictive type diets. We talk about like the micronutrient deficiencies that can develop if they're not getting, standard caloric intake.
There's a question in the chat from Peter Janu. He asks, if you choose to pre-op GERD patients with a borderline BMI with the GLP-1s, do you recommend refer to endocrine, PCP, for management, or should patients expect the surgeon to initiate and manage?
Good question. Good question. We have obesity medicine specialist in our team. It will be referred to him, to Daniel.
Yeah, so I might have 2 nurse practitioners that are dedicated only to prescribe medications now in our program, because we see, we see around 1,000 patients a year in preparation for surgery, for bariatric surgery and the foregut. So actually we're able to convince this health system to provide us 2 outpatient NPs just for that.
Yeah. We similarly we have an endocrinologist embedded within like our multidisciplinary clinic. If patients have poorly controlled diabetes or other endocrinopathies, many times we will engage with that person. I do think some of our physicians, including myself, feel comfortable prescribing these medications and titrating them and using them, but it just all depends on understanding what your networks look like. And I don't think it's a one size fits all answer for practices. I think it depends on what your resources are and what your comfort level is with these medications.
Yeah, and if you are a solo practitioner or in a private practice, sometimes it's difficult to manage these patients because you need to titrate meds, you need to pay attention to their. So you need to basically phone a friend, find someone who will be able to help you with that. And there are a lot of obesity medicine physicians, and some PCPs are now pretty smart. Cardiologists now are the bigger ticket item, right? These medications are easily approved for patients with cardiac disease now.
That's right. And we do have another question in the Q&A that refers to the last case that we did, and we're getting short on time, so I'm going to go ahead and read it now. Mustafa is saying he has a patient who had a sleeve gastrectomy a few years ago. Now the BMI is 36, and the patient has severe GERD with a Demeester score of 77 off PPI. They have an upper GI series that shows a small sliding hiatal hernia, but the insurance will only approve for a hiatal hernia repair. So if you plan to use a GLP-1 and then do the hiatal hernia repair, at what BMI would you go ahead and operate on that patient?
You shouldn't do a hiatal hernia repair in a patient who has post-reflux after a sleeve. Hiatal hernia repairs alone was the initial anti-reflux procedure proposed by the father of anti-reflux surgery, Philip Allison, and he proved that it fails in the long term. Hiatal hernia repair alone in post-sleeve will also fail. These patients either need to have a conversion to a gastric bypass, and Lina Caetan has published outcomes using a LINX as an adjunct to the repair. However, even the data from the LINX, the magnetic sphincter augmentation device that Lina published, it does not decrease the Demeester score from abnormal to normal in about 2/3 of the patients. And I presented the AFS. We are writing the manuscript. We have about 70 patients converting sleeve to bypass, always repairing the hiatus, small gastric pouch. That is the better approach to it. But if a patient cannot have a bypass, and then the only option, or does not want to have a bypass, the only option is an anti-reflux procedure. You need to either use a LINX in addition, but the results are not as good as with the bypass reflux-wise.
Yeah, and you can see here on the in between the lines, if I can say that. So the Demeester score is huge, and the hernia is small. So is the sleeve refluxogenic mechanism that's playing a major role there. So meaning that you can anticipate, and I agree with Guilherme that the hiatal hernia repair will not gonna work on that direction. So I will exhaust my possibilities with the insurance, and we will appeal for that. And generally, if you appeal, you can make them understand.
Yeah, and then I always like to take a step back. Sometimes we jump in answering this question. Make sure that the sleeve is actually intact. There's no stricture, right? And because if there is a stricture at the sleeve, you cannot do a LINX. And if you do a bypass, you may as well just resect the rest of the stomach.
And when you're appealing to the insurance company, again, would this be the time to do a Bravo on PPI?
I will use everything in my power to benefit the patient, because ethically is what we have to do. We have to do a gastric bypass ethically. And then now we're trying to fix the day-by-day problems. But ethically, I have no doubt, we have to do a gastric bypass on this patient.
I do wonder if there are, I mean, obviously there's anatomical, depending on how big the bypass, or sorry, the hernia is, but is there a medical option where you could use a GLP-1 with a PCAB, for instance? We use a lot of PCABs in practice because they are really efficacious for acid suppression therapy. So you may buy some time while you work with the insurance companies, at least if there is esophagitis present, you're healing it, you're treating the excess acid irritation within the esophagus, and you're also helping with weight loss, which may help with some of the hiatal hernia limitations.
Yeah, obviously medical therapy can be instituted and should it, especially if you're not trying to heal esophagitis. Um, and maybe there are a proportion of patients who will improve with medical therapy only, but they likely will need to stay on medications for the long run.
Mhm. Okay. Well, we're almost out of time. Those were our 3 cases. If there are any additional questions, oh, he just updated us and said planning for bypass, but insurance refused to approve. Yeah, so you got to keep fighting or see if the patient can, I guess, come out of pocket to try to get the surgery that they really need. But yeah, so
Yeah, one alternative that we have done is to actually, talk to the hospital so they would eat the costs. You bill for the higher hernia and and you do the gastric bypass and the hospital eat the costs. But it's rare that they will accept uh, because it's money. But I was able to convince once my hospital to allow me to do the higher hernia repair alone.
Yeah, we
And the bypass.
same point here. And also we have to think about the liability of the option of just going repair here.
Yeah.
good point. All right. Well, that's all we have. Carolyn, do you want to send us off?
Sure. Well, I just want to thank all the panelists for being here this evening. I think this was a great multidisciplinary discussion, which was the goal of this webinar. Thank you so much for all of our participants here that asked questions and were here learning with us. I mean, there's definitely a lot of opportunities for research in this field to be able to better define predictors of positive and negative outcomes in these patients that are undergoing surgical procedures. And so we look forward to learning more about that. And with that, I think we are all set. So thank you so much.
Thank you,
Thank
guys. Good
you.
seeing you, Caroline, Manuel,
you.
and Catherine. Thanks everyone in the group.
Thank
Yeah.
you.
Have a good night.
Bye.